The title will be that we talk about one of these 4 options I presented to you. This is the option we have done most often and where we have done a lot of documentation, and therefore I want to show it to you. And there we talk about selection of biomaterials, bone grafts, and growth factors. Okay, so I stopped with this slide with the 3 options: immediate placement, early placement, and late placement. And again, I want to stress this. We're not in a world of either or. We are in a world of using all of them to different ratios, percentages. And some master clinicians like Dennis Tarnow told me I'm always doing almost immediately. He said, that's fine with you, you see. But probably Dr. Joe Average should not do that. Otherwise, he will run into major problems with this technique. So everybody has his own decisions, how often he's using what, and I want to show you that the middle one is a very good alternative and actually very attractive because you get excellent outcomes, low risk of complications, and the time period to treat the patient is between 12 and 16 weeks from extraction to provisional restoration. I think that's the point I want to make. So we start with the surgical technique to show you step by step the ingredients of this technique. And I mentioned that we described this technique in a paper of 2008, but we did the first case like this in 1998. That was where we changed from Gore-Tex membranes to collagen-based membranes. And then we figured out that autogenous bone and collagen membranes alone does not work because we lost the result very quickly. And then had a thorough discussion with my mentor at that time, Professor Bob Schenk, talking about what the heck is going on, why don't we see the same results, do we have to change and select a different biomaterial? And I will tell you then what he told me. Okay, early placement described here, and this is the middle option. And the trick, or let's say the background of this technique is that when you go in at 8 weeks and you have done the extraction flapless, you are not going to have a problem with reach alterations. Actually, you're favoring this situation because all the bundle bone is gone. And what also very important, you see, when you pull a tooth, a week later, you have tons of osteoclasts in that site, and that's not in your favor because they are eating up the bone, and you want to rebuild the bone. So when you go in at 8 weeks, all the osteoclasts have disappeared. And this is an important aspect to make this procedure very predictable. So you want to have then this two-wall defect, and as we have learned from Professor Schenk, the bone formation comes from the bony walls. There are the blood vessels and the pericytes, as they are called. These are the cells who are able to produce the bone. They are forming to osteoblasts, the precursors. Okay, I want to show you one case step by step, another one just short clips to explain that. This is a 38-year-old female. She just delivered a baby, and she told me that she wants to now legalize her situation with her partner. So she has a wedding in 12 weeks. And then she found out that she has a fistula here, and this is the reason for that. And she said, look, I have to get rid of that tooth, obviously, but I don't want to go to that wedding with a flipper in my mouth. Can you help me? Said, yeah, we have to speed up a little bit, but it should be okay. High aesthetic demand, non-smoking and healthy, thin tissue biotype, highly scalloped triangular teeth, lots of risk factors, high smile line, and chronic infection with a fistula. For me, that's not an immediate case, because you're just asking for troubles when you go in here with an immediate implant placement. So the local bone anatomy was favorable in terms of the bone height mesial to the tooth. Here already some bone loss due to the infection. Not favorable thin wall phenotype, very thin. And that's favorable, excellent width of the crest. So you measure the crest width 3 millimeters apical to the future mucosal margin. That's where the implant shoulder will be. And when you see there's 6 millimeters plus, you know I'm on the safe side. Nothing will be a problem, because at 8 weeks, you're going to have 6 millimeters plus. That is the key when you do the cone beam analysis. Okay. Here you see the risk analysis. This is the ITI treatment analysis. We call the aesthetic risk assessment. So we have a couple of red colors, but this is not a complex case if you use the right technique. And then we did step 1, flapless extraction, very careful, rotational forces, take it off. If that should fracture, then you do a separation of the root. Never raise a flap, very important. You need magnifying glasses, special lamps, and dig it out without any troubles. Don't raise a flap. And that's fine. We degranulate the socket. We use often a collagen plug to stabilize the clot, but no bone filler now, because that would be a waste of money, because at 8 weeks, nothing will be integrated there. Okay. Then, in this case, 6 weeks of healing, it's a small tooth. The big advantage of this approach, you let the soft tissue heal. So you get more keratinized mucosa. You get a spontaneous soft tissue thickening to work with when you go back in. And from a biologic point of view, you let the bundle bone resorb. That will take place. The osteoclastic phase will be there as a biologic reaction to the extraction, and you're going to get significant vertical bone loss, but only mid-facially, which is not a problem. This is just the biology. Step 3, implant surgery. I know we're going to have tons of discussions tonight with Dennis Tarnow again, because he is often a reviewer of our papers. And in all fairness, he normally tells me that he has reviewed the paper once later, and he said, excellent paper, but one mistake, your incision technique is very poor. And this is the constant discussion. I have to say, there are no colleagues in Europe that would tell me the same. This is just Dennis Tarnow and a few Americans insisting on this. And I will explain to you. Each of these flap designs and incision designs has advantages and disadvantages. It's a trade-off, you see. What is more important for me? And that's why I made the decision 10 years ago to go for the triangular flap. This is the European style. Uli Grunder, all the Italian top shots in the perio field, they go for triangular flaps. So what are the advantages, disadvantages? This is this papilla-sparing incision, Dennis approach. And of course, there are good arguments for this. We know that when you elevate, if you don't touch the papillas, you're going to get less bone resorption, because we know there is a paper, Gomez and Roman in 2001, that you lose about 0.5 millimeter of bone when you mobilize the flap. This is a given fact. Disadvantage, it's a small flap. It's not easy to deal with, and when you go for contour augmentation, what I want to do, I add a lot of volume, and then it's difficult to really have a nice, careful apposition of the flap margins, and then the result will be scar lines in an area where you don't want to have scar lines. That's very easy. And when I sell a patient, you see a treatment which is, I don't know, $5,000 at the end, and then on top of that beautiful crown are 2 scar lines. They don't like that. They complain about this. That's the reason why I don't like to have this incision line, because this incision technique. But we're going to discuss tonight at the party. Yeah, I know, this will be fun. Okay, sulc incision and trapezoidal flap. That's what I learned as a young postdoc student in the early 80s. This is the typical oral surgical approach. Distal line angle to either side, then you have a trapezoidal flap. Big advantage, of course, it's a large flap, excellent vascularity. Disadvantage, you have 2 releasing incisions. They are within the aesthetic frame, because often then they are at lateral incisors, and the papillas are elevated. So I would say we have used that for many years, and we have given up with the input of Uli Grunder and all the Italians about 10 years ago. We have given up on this. So the triangular flap design offers a lot of advantages. First of all, it's only one releasing incision. And second, it's always remote. So you get distal to the canine, sometimes even to the first premolar, if this is a gummy smile case. And the advantage is excellent vascularity. You can easily cover contour augmentation because you're just tenting out. Only one releasing incision. Disadvantage, you elevate the papilles. Okay, now the point is when you lose a 0.5 millimeter of bone and there is enough bone there, then that's never a problem. I do not see black triangles in my cases. Of course, I have excellent prosthodontists. If the level is already slightly reduced, then they have to have slightly longer contact zone to avoid a black triangle. And that's how they deal with that in a case of a compromised situation at the beginning of the treatment. So now I show you a video clip of that lady, and this is on the IGA Online Academy, one of the video clips we have provided to this platform. And this is from a master class. We have 3 of them at University of Bern since 2000. And we have a lot of visitors, but not from the States. So obviously from the States to Switzerland is too long to fly. And of course, when I see the Dental XP competition here, I'm not surprised. Good. So you see, we have had a mid-crestal incision. We go to the canine, and since she has a very gummy smile, we go for a papilla base extension and go to the first premolar. What I did in the mid-crestal, this video has been taken 3 years ago. In the meantime, we have seen more and more data from this soft tissue study and also a little bit on this bone graft story, and I will explain that to you later on. So I would say we have slightly modified. Here you see how we try to capture the soft tissue inside the alveolus and have it as part of the flap. The big advantage of this is that you have an excellent flap thickness. The releasing incision is slightly distal to the canine, as I said already. You see the flap is mobilized, and I will show you then this technique again with the next clip. Okay, I mentioned this study in Journal of Dental Research. Of course, you see, I got immediately criticized by Dennis, yeah, but that's only half of the story, because if you let that heal for 6 months, then it will slim down the thickness. I said, of course, but we put the implant in at 8 weeks. That's the point. When I go in at 8 weeks, I have this thickness, then I take advantage of a large flap, or a thick flap. If I wait longer, then of course you see the modeling, and then the bone starts to move in, and then might be possible that then the soft tissue thickness will be diminished. What we do not know, and that's all in all fairness to Dennis again, you see, we do not know if this 5 millimeter thickness will stay on there, and that's what we are doing right now in a clinical study to figure out how stable that is. But there are lots of people that are doing connective tissue grafts for years. I do not know one single study that really studied that so carefully to say how much is lost when they have applied it. And when I can have a thick flap like this, and it's part of the flap, and combine that with a free connective tissue graft from the palate, ask me what is better in terms of vascularity. It's for sure this approach, because it's part of the flap. It is vascularized, and the free connective tissue graft is not vascularized. You agree, Morris? Yes? I mean, that's a little bit mind-provoking, I know. And not every periodontist will love this study, you see, because they see that they're going to lose some business here. Okay, so that's just to have something to talk. This is a second patient we did just about 4 weeks ago in a master class, very similar. You see also here a root resorption, and the tooth has been pulled. 8 weeks later, we went in. Now you see, today now I go really to the palate and try to feel with the tip of my blade the palatal rim. And then when we We do then the incision to the distal, and then when we go in, I take a microblade because that's the easiest then with the approach. You try to feel that the inner surface of the socket, and then you go all the way down to the apex and make this movement, and then you can maximize to have all the soft tissue as part of your flap. So, and look, you have to work a little bit because you have to use the right instruments to really free it up. This is the setup we have. Up here is the camera. Of course, you have to do that very carefully. Could be that should go forward. Yes, I think it should go, yes, here. Here you see now, huh? The next step, and I know that Maurice is immediately thinking about it. So you have a case where there is a thin facial wall and you go for early placement. You know what I do these days? I pull the tooth and I go in with a diamond burr and take this thin facial wall off from the beginning, so it doesn't have to be resorbed, to immediately allow the ingrowth of soft tissue to have a very healed soft tissue inside the socket. Maurice loves that, I see that. Okay, so I think we can move on now. Okay, now we talk about facial contour augmentation. You see the site has been exposed, and now we start to talk about what kind of bone fill you should have. We have different bone grafting materials, autografts, allografts, xenografts, and alloplastic materials. And here you have all the various subtypes of all of them. Now, when we talk about bone fillers, then we have two characteristics we have to talk about. One is the bone filler able to accelerate the formation of bone? It's like an osteoinductive or osteogenetic potential, you could say. And is the filler stable over time? Does it resorb, or is it low substitution rate? These are the two characteristics. So far, to my knowledge, we don't have one who fulfills both at the same time. That's why this discussion with Bob Schenk in the mid-90s, he always said, Danny, don't give up autogenous bone chips because there's something magic in there. I don't know what it is. I'm too old to understand this molecular biology, but stick to it and try to figure out with your team what you have in there. Okay, so we have a huge wave of bone fillers. I know in the States slightly different in Europe. And I think when reps are coming to your office, you just ask them what's the osteogenetic potential, what's the substitution rate. When he says, what? Then kick them out, because they don't understand anything what they are selling. And you check both of them. So you should only use something which has been carefully tested in preclinical and clinical studies. Here, preclinical, also histologic studies, or in vitro studies in tissue culture, very important. Okay, so with Bob Schenk, we made that decision in '98 to go for autogenous bone and for deproteinized bovine bone mineral, DBBM. This is the BIOS bone filler. And we also decided to go for a collagen membrane to avoid a second surgical procedure to eliminate the membrane, as we have done before that time with Gore-Tex. So that was something to help the patient to have this procedure a little bit less morbidity. And you see, this is the paper that gave us this idea with collagen membrane. You will see tomorrow Mark Hürzeler, and this is a study he did in Houston with Cafesi. And I saw this study first time in '94 in Toronto. It was a big GBR meeting. And I went home and thought, we have to look into collagen now. I think it's just time to do that. And that's how we changed. We did not do a lot in that field. We focused more with Bob Schenk on bone fillers. And I would like to show you two of these studies that really nicely illustrate very consistent findings and always the same in all the years. 2008, we have used the mini pig as an animal model, could prepare very standardized defects, put on top a Gore-Tex membrane to really exclude soft tissue interference in the healing, and then studied the growth of the bone. And you can see here, 8 weeks, this is Biomaterials, autograft, Biomaterials and TCP, no major differences. You can see, of course, here more fillers than here, but no major differences. But we have a collagen membrane. We know that degrades rather quickly, so you need to have something which helps you in the initial wound healing, not at 8 weeks, because this is with Gore-Tex membranes, this animal study. And what we have seen that at 2 weeks, and this is amazing, 2 weeks, 5 millimeter defects, and at 2 weeks, the autograft sites were completely healed with woven bone, completely bridged. And here you see why. You see these autogenous chips, they serve, it's often called a scaffold, and they obviously boost an osteoblastic reaction, and they walk in thousands and delay, also put this osteoid and then the woven bone into that defect. And you see that beautifully. This is the fantastic histology we have gotten from Bob Schenk. And you see at 2 weeks complete bridging. Bob Schenk always said that the other fillers, they delay the ingrowth of osteoblasts. It's like a hindrance in the early phase. That's not their big characteristics. The beauty is coming. Why this DBBM is so good? That's not to speed up formation of bone, because you see that here, when you look new percentage of new bone formation, osteogenic potential, this is always the big winner here, autogenous bone. This is running behind. But that is the other one. That is the substitution rate. Is it resorbed, yes or no? And you see autogenous bone resorbs quickly, TCP quickly, and DBBM stays stable. And that's what we learned. When we want to build out the bone and want to have a stable long-term result, then it should not resorb. And that was the argument for this combination of autogenous bone and DBBM. There are other fillers, of course, that have the same characteristics with a low substitution rate. That's why you should focus on these fillers to be used in this application. There's another study by Jensen, Simon Jensen, published 2009, was a 52-week specimen. And here we confirmed, you see, up to 52 weeks, as of a full year. And you can see autogenous bone in terms of the speed up, much better than all the others. When it comes to the substitution rate, this is BCP, biphasic calcium phosphate with TCP and hydroxyapatite, different ratios. Nothing is as good as DBBM in that study. Okay, that's why we are using this combination. Okay, so this is important. Now we want to have morbidity low, so the bone has to be collected locally, so not in the chin and not in the retromolar area. Of course, we need these harvesting sites when we go for larger defects, and I'm sure Michael Picos will show us some fantastic cases when they go for the large block grafts, when they are continuity defects or really large defects, but not in a post-extraction case like this. Okay, so you see what we do. We open it up, then we have access to these bony surfaces, take the blood, take the chips with a sharp instrument, as a bone scraper or bone chisel, and then we put that into the blood and we store it in that blood for the next 15 minutes, because we then continue with our surgery and these bone chips are there in the blood. Here you see how these bone chisels, also bone scrapers, can harvest this. When this is done, we put the implant in. And of course, we mentioned that this morning already, and this is common knowledge. We have to have a correct position. ITI has had a consensus conference in 2003, and the paper was then published in 2004, defined the so-called comfort zones in all 3 dimensions. And most important is that the implant shoulder is about 1 millimeter to 1.5 millimeter to the palate from the point of emergence to be inside the bone. That gives you then the two-wall defect morphology. And then you have a good chance that Mother Nature is going to regenerate that defect very predictably. I mean, that's the goal of this bone augmentation procedure. So we prepare the implant bed. We also have to keep an eye on the axis. That's clear. In a single tooth sites, I normally don't use a surgical stent. I do that when we have multiple missing teeth, because then I want to have a stent with an open structure, so no sleeves, with the incisal edge, because that gives me then an indication of how the axis should be. And it also contains the future mucosal margin of the restorations to know how deep I put the implant in. Today, with the platform switching implants, we normally use a 3 millimeter distance from the mucosal margin to the implant shoulder. I think also this is a fairly accepted distance by various groups using different implant systems. Okay, here you see that the axis is not yet really perfect, so with the next drill, you can easily correct that to get it inside. Okay, when this implant bed is prepared, then we put the implant in. This is done with a slow RPM of 15, no cooling. And here you see this is a Straumann implant system, so this is the 3 dots indicate different measurements, 1, 2, 3 millimeter. When we are putting in an implant in a lateral incisor, then of course the crown is slightly smaller than the central incisor. That depends on the contralateral tooth. So I would say in this case we decided to have the second dot, the 2 millimeter mark, at the same level as the CEJ of the central incisor. That was my orientation when we put that implant in. Then important, of course, as I mentioned, this exposed implant surface is inside the bone. The palatal implant shoulder is below the crest. That's also an important one. And now comes that we always use a healing cap on top of the implant, which is at least 2 millimeters in height. Here it's even 3.5. And then to perform an augmentation to the healing cap. The goal must be that at the end there is a bony rim on the facial which extends further coronal than the implant shoulder itself to support the soft tissues. This is something you don't get with immediate implants, as we have seen by this Linden Cooper's paper. Okay, I'm sorry, this is, probably you have seen that already. So here we go, yes, now you see. The implant is inserted, the healing cap is inserted. When you see that here the exposed implant surface almost at the surface of the bone, and when the bone is very cortical, then I would recommend to open it up with small perforations to open up the blood vessels, also to open up the spongy bone to allow the ingrowth of blood vessels. That's most important. We know that for bone formation, the first step is the ingrowth of blood vessels. And now you see that the autograft chips are applied. They have been taken now from the sterile dish. When there is not enough, you can still grab some additional just next door. This is all in the vicinity of 1 centimeter. That's the beauty of this technique, and it's actually free of charge. You don't pay for that. That's another one. Huh? See, for such a case, I would never want to pay for a growth factor of $500, because we have to stop to make these treatments more and more and more expensive for our patients. We are cutting our own flesh when these are so expensive that only a small percentage of the population can pay for that, or can afford it. So you see then we have applied the second layer, and now we trim the membrane. I take here a 25 by 25 millimeter membrane in 2 pieces. The blood we have had in the bone chips is also used for the membrane. I will come back to that. And you see it's in a syringe. The membrane is rather stiff in the beginning, and the moment you soak it in blood, it becomes very soft and easy adaptable. And then in a case like this, there is no need for tacks to fix that membrane. That's only when we have very difficult situations, what, for example, Istvan Urban is doing for this sausage technique. Then, of course, you have to use the tacks to stabilize it. We use this double layer technique for such cases, and many of them are in this situation, and then we get a very good stability. Okay, and then you see the flap has been released in the periosteum, and then you go for a tension-free primary wound closure. As I mentioned, I'm not available here to go for immediate restorations in a case like this. I want to protect these biomaterials for 6 to 8 weeks to get a maximum tissue healing, and then we go in and continue the treatment. It's just a little bit conservative Swiss approach. Okay. So 6 to 8 weeks is our healing period. 6 is only when there is more or less an intact facial wall and you do the internal grafting. And if there is a crater-like defect, then it's 8 weeks. And here you see this was a 6-week healing because of the wedding. We had to do it, you see, because 3 days later the wedding took place. That's the provisional she has gotten from Schule Wittneben. In the pros department, soft tissue conditioning for 3, 4, 6 months. There's no urgency then, patients are fixed. And then she was restored in private office. This is the radiograph from the 6 months follow-up. Everything looks fine. Here I could not take another radiograph because she was pregnant now a second time. So we will see. She will come soon for 3 years follow-up, and you see when we summarize now these secondary objectives, we can say we got a decent aesthetic result, patient a low morbidity, 1 open flap procedure, simultaneous GBR for contour augmentation, no graft harvesting from the chin, no graft harvesting from the retromolar, no connective tissue graft from the palate, and the overall treatment time from extraction to a fixed provisional 12 weeks. Not bad from my point of view. Okay, another case now, patient is 28, post-trauma, and she has a complete loss of bone. You see the fistula. This is the 3 years follow-up. And here you see the radiograph at the beginning, at 3 years, the cone beam, and the extent of exposure we had was a large defect. It worked beautifully. We could take the cone beam because she lost another tooth, not next door, but 1 tooth remote. Or now a compromise case, you see, in cases like this, you cannot get the perfect results because we have already vertical tissue loss, therefore the short papilla here. That's because we have already a short papilla here. So you try to maximize or optimize the outcome. Patient has been absolutely happy, you see. But compared to a very young patient, of course, you would say that can be done better because the preconditions are better. And here you see the radiograph at 3 years, and you see very typical, the implant crown is absolutely stable. The natural teeth continue to lose soft tissue with a little bit of recessions. The only structure that has a thick facial wall is the implant, not the teeth, obviously. Or another case we have shown many times is a video case from a Quintessence video, DVD. Is also a high-risk case in terms of gummy smile and everything. And here you see the patient 6 years, just 3 weeks ago. And you see we got a very decent result, also done by this Dr. Wittneben, a young prosthodontist who was trained at Harvard about 5 years ago. Okay, other applications, of course, that's not only for early placement. We use the technique also for failed implants. This is another topic I'm working on with Urs Belzer, and that will be this quintessence book we want to write during my sabbatical. You see, here you see how we remove the implant. Today we are using this implant removal kit of Dr. Anitua, this BTI kit, but here was not available. And you see, we did a soft tissue grafting, we did a socket grafting or defect grafting, and we could reinstall keratinized mucosa with a mucosal graft from the tuberosity, also full thickness, partial thickness. And here you see then in a healed site, more or less, contour augmentation with autogenous bone, DBBM, membrane, and primary closure. And then at 8 weeks, provisional. Of course, we have had black triangles because she has had before about 3 surgeries already. And now we just let Mother Nature do the job. You see the recession here from all the surgeries by the original colleague. It's getting better. So the soft tissues are stretching in. And here you see then how we started and where we have been at 1 year. And here you see the patient at the 4-year follow-up. It's not 5 years now. 4 years, and I have to say I'm very pleased with this outcome. Of course, we still have a mucosal recession. I tried to talk her into a soft tissue surgery by Tony Sculian to fix that, because then she would be perfect. But she tells me, why should I? It's just for my camera, she says. And this is the implant at 4 years. Well integrated, obviously on the facial, we have bone to support the soft tissue. Another one, an implant failure that was not even restored. When they did the reopening, they saw just that the implant was exposed. Then the patient was referred to me. And here you see the problem. Malpositioned implant, too far facially, so the tissue could not form. And here then the surgery, a triangular flap. See, implant was removed with such an extractor instrument and replaced, same surgery with a new implant in a better position. And then our technique, autogenous bone and DBBM, membrane and primary closure, and let the implant heal for 8 weeks. And then Urs Belzer took over to do the restoration. And here you see then the provisional crown. Also, she has a little recession at the gingiva at this tooth from beginning. This is the implant. Dennis, not so bad, although we mobilized the papilles. And this is 5 years. 5 years down the road, very stable. And look this facial wall. It's a fantastic facial wall. Obviously, from the side, bone was growing into the bios. And now we have the stability. Last case, also, of course, multiple missing teeth. We do about 40 cases a year now, many of them. And you see post-trauma situation with lots of vertical tissue loss. We removed the teeth, could not maintain them. And then we did the same augmentation. In our group, we never place 3 implants. We want to avoid adjacent implants as much as possible. And we want to use the pontic area for vertical augmentation as much as possible, and then go for GBR. And then you see here the patient with a provisional. This is the 5-year follow-up. And this is the periapical. with a diameter-reduced implant and a tissue-level implant. And this is the cone beam we were able to take and look the bony situation we have. Also in the pontic area, excellent result. And 2 weeks ago, I saw her again for 10 years follow-up. So this is our lady. That's how we started. This is now 10 years, 10-year follow-up when she smiles. And the radiograph shows absolute stability, and you still can recognize the DBBM particles, but they are stable. Because I'm sure, of course, I cannot prove that, they are osseointegrated because embedded in bone. Okay, now what about the long-term results? You see, this is an indication, single tooth replacement, early placement contour. We did a lot of efforts, and these days that's a lot of efforts, you see. Only the right ethical applications and fulfill all this paperwork, this is crazy. Same in Switzerland, that's I'm sure same in the States. Huh? It's getting worse and worse. See, we have published several papers, and I show you the 2 long-term studies. One is 5 to 9 years. Actually, this has already now, it was published in 2013. And you see we analyzed twice, 26 and 2010. And you see the clinical parameters did not change over time. One patient, just a typical tissue-level implants. So we have a little saucer here, which is typical. But you see nice facial wall, although there was a large defect here. And another typical patient, more than 60 years of age, typical crater-like defect at 7 years, fully reestablished facial bone wall. We were able to measure with cone beams the facial wall. And here you see that one obviously has no facial wall. We had actually 2 of them out of 41, and both of them showed the same malpositioned implants. So there was no 2-wall defect morphology. The bone could not grow into that augmentation material, and then when the membrane was resorbed, it was completely resorbed. I think it's very important. These are the measurements we have taken, and you see the mean value is between 1.5 and 2 millimeters, which of course is fine to support the soft tissues. And here you see that's why it's so important, the frequency distribution. 2 out of 41 did not show a facial bone wall. It's a 5%. And both triggered by not optimal 3D positioning of the implant orofacially. The second paper is a 6-year study, and that's an interesting group because it's 20 patients only. It's a case series and published after 1, 3, and 6 years. And now this year, we're going to see them all again for 10 years follow-up. We have not lost one patient, so all of them are still under control. You see also here the clinical parameters are stable, 1 year, 3 years, 6 years, no dropouts. You see one example that shows large defect here, and at 6 years. Another patient is even better. When you look why, you see excellent defect morphology. Deep 2-wall defect gives better results. That's tissue biology. Okay, we did not have any recessions in the group. Here you see, of course, this is the whole range of ages. I think the youngest was 22, the oldest was more than 70, and you can see that the neighborhood sometimes is compromised. And you can also see that 4 patients showed continuous growth in the alveolar process because you see a step in the incisal edge. 4 patients showed that. That's an interesting question. We are currently analyzing a group of patients, 155 single tooth cases, 10 years plus, and I have not heard about the analysis, but it will be interesting. So we did a cone beam for all of them, of course, and you see that in 70%, fully intact facial wall extending coronal to the implant shoulder. 25% intact facial wall, but a little bit of bone loss. and one did not show an intact facial wall. We call this Mrs. M, our risk patient, and that's 5%. The mean values were quite okay. Okay, so conclusion, very stable results, no facial recessions, and we're going to see them again this year for 10 years, and ethical approval is here to go for another cone beam to see. Okay, last question is, what is in that facial wall? Because we don't have histology, we only have radiology. And that's a tricky question because we cannot go and open up our patients to take a biopsy. Nobody would approve that. What we had, and this is a very interesting paper published in 2014 in Journal of Perio. In 8 years, it happened to me that some patients got this contour augmentation and then needed another implant, 2 teeth next position, for example. So we had to go in and raise a flap anyhow. And then they accepted that we take a biopsy, so they gave informed consent, and then we could collect histologies. And you see we have 11 patients and 14 implants. The mean time of implant in function, 43 months. I show you only one patient, you see, 2004. Implant placed, contour augmentation, as we have seen, restored in private office with the crown and the cantilever. And then she fractured this tooth. We went back in 8 weeks later, took a biopsy, and here you see the biopsy. This is human tissue, 4 years post-contour augmentation. And when I give you close-up view, then you see this is DBBM, and this is bone, and this is living bone because you see everywhere blood vessels. And those who understand bone histology, you see a lot of cement lines. That means that we have had ongoing bone remodeling in that field, but the osteoclast could not eat up the bioos. This is an interesting phenomenon, but it has shown in all the studies we have available also by other groups. Look at the cement lines here, the blood vessel, everything, but untouched DBBM particles. And when we analyzed histomorphometrically, you see the range of the percentage of DBBM was between, I think, 19 to 42%. On average, 32%, similar to what we have had in our animal studies. So that is the first human biopsy study that confirms the low substitution rate of this filling material. Okay, I still have 12 minutes, as I'm not too early, don't worry. I will show you now a little bit future directions. The conclusion now first. Only 2 slides. One is early placement with soft tissue is preferred in many patients by our group. Gives us good to excellent outcomes depending on how you start. And a low risk for facial recession. So it's a very predictable procedure. And I'm absolutely sure you don't have to be a master clinician. This is mastered by all my postdoc students, and it works by my postdoc students as well. That's the beauty. Early placement is combined with rather short healing periods. Contour augmentation is routinely performed, and we are using non-cross-linked collagen membranes to eliminate the reopening with an open flap. Contour augmentation in aesthetic implant dentistry is a surgical technique very well documented these days for post-extraction implant placement, has a low risk of aesthetic complications. The combination of autogenous bone that offers faster healing and shorter healing periods, and DBM particles gives you a better augmentation volume and long-term stability. And both, you see, has been documented long-term, and the 2 long-term studies have used cone beam technology to document the facial bone wall anatomy. So I'm convinced today this recommendation of Bob Schenk has been a fantastic recommendation. See, he passed away 4 years ago, was a very sad day. But of course, he was already 88 years, and he wanted to die because he had a disease, not Alzheimer, but just it was time to leave. Huh? But this combination of autogenous bone chips and DBM particles gives you these excellent results. And that's why when we established in 2008 at the dental school a new cell biology lab, we said now it's finally time to look into that. Now I have to tell you, I do not understand too much of that technique because this is cell biology. This is really basics. Huh? That's why you have to team up with excellent experts in that field. And this is, I would say, the first two sentences have always been used by Bob Schenk. He said, see, particulate autograft contain, he called them non-collagenous proteins. In the book chapter in the GBR book written by Bob Schenk, he said these non-collagenous proteins and growth factors in the bone matrix. Now, when we take the bone, we get these bone chips like curled. So it's a small volume, large surface. Also you break up the matrix. So you have everywhere the bone matrix wounded, and so all these growth factors are exposed to the surroundings. That was his argument. Okay, what we have seen now is that these proteins are liberated into the medium or into the blood, depending where you store it, during initial healing, and this accelerates obviously new bone formation. And about 4 years ago, when we had the first studies analyzed and started to publish, we called this bone conditioned medium, BCM, a nice abbreviation. That would be BCM, the liquid here. So this is the bone chips taken, stored in blood. Of course, today we take more blood to have more of this. And the technology, how this was analyzed in these cell biology studies, this is a Spanish collaborator, Jordi Caballé Serrano. You see, very smart young dentist, was really top sharp. See, we took the bone from a mini pig bone from a butchery, you see, and then of course did not use blood. We used then a medium for tissue culturing. And then they were running tons of studies, and you see, these are all the papers we have published the group since 2011. Some of them in top-notch journals, so actually in total 11 papers. About 6 of them are using in the title BCM. And today just the last one got accepted, and Jordi said, the saga continues. I think we still have a few studies to run. We have not done yet autogenous bone from patients with blood from patients. That's not so easy, and of course then we get into ethical committee again. With the pigs, there's no ethical committee. Nobody cares. Okay, and here you see 2 of the most recent ones, very interesting. I don't want to explain that too much, but you see this is done, they have used this BCM liquid and put them on membranes for a given time and then took them out and then seeded cells on these, and they could show that they picked up the growth factors very quickly. And then they have like an activation of these membranes, and the same also with DBBM. Also for those who are interested in this kind of research, that's interesting papers to read. And I would like to show you how we have now altered our surgical protocol. This is this patient I showed you where we did the incision line, and you see you can take the bone from the nasal spine. This is the implant site, and this is about 2 minutes later in the extension of the lateral incisor from that bony surface. So we take bone from both places with sharp instruments, and this goes into a glass dish with blood from that patient. So you see that here. So this is like a bath of blood and with the bone chips of that patient. We do that as early as possible, and then it goes to the sideline and we continue. Implant bed preparation, release of periosteum, everything is done. Okay. Now here you see what we do then. About 15 minutes later, we have these glass dish with bone chips. Now we put sterile saline into that blood, mix that, so we dilute it a little bit so we have more liquid. And then I take a syringe and soak up the liquid. And that liquid is then used for the DBBM particles. That goes to the other side. And then immediately, if there are proteins in that liquid, then the DBBM particles will pick up these proteins and we activate the DBBM. You see that, huh? This is from a master class. You see now the implant is inserted, and here you see how this bone condition medium now is used to soak the DBM particles. Now the bone is applied, and you see these days we take nice volume. So we activate that whole area with the patient's own bone. And then, of course, we go on top of it with a second layer of DBBM soaked in BCM. And then at the end, the membrane on top of it also soaked in BCM. So now here we are on thin ice because, as I said, all the tissue culture studies were not done with human bone chips and blood. That has to be done. And we have to first get approval to harvest bone and then use it in the tissue culture lab. But this is the next step we want to do. This is a master course, you see in Bern, with a top camera on top, and then you can produce these nice video clips. Okay, last slide. What about PRP, PRF, LPRF, or PRGF? We have had a very interesting lecture this morning by Eduardo Anitua, and I tell you that actually we are very interested in this field as well. Because I tell you frankly, when we had the first type on PRP about 12, 15 years ago, as many others, we started to use it. We did 2 animal studies, and we did not find anything. Both were published. When the first was published, we got hammered by Bob Marks in iChomi, what a lousy group we are. And then Chomi gave us the prize for best publication of that year in iChomi, you see. That was sort of an interesting experience. Obviously, we hit the nerve there that somebody with an interest did not like to see what we reported. We did not see in both studies anything, no effect of PRP. Now we have, in the last 8 years, let's say a second wave of blood-borne growth factors. And we have several techniques. And I'm sure also several abbreviations, and I'm sure you're all a little bit lost what to think about it, because now you have PRGF, PRF, LPRF, PRF. It's a complete mess. And I would say some of the groups have an invested interest, so it's difficult to really figure out, is it something or not? We decided now to go with our group into this and test the most important techniques, and we thought we are the more independent, and then we will see. I hope to see something, because I think it's important. Because when we talk about future directions, we continue to search for bone mediators, you see, which could stimulate. I don't think that we need them in these standard techniques as we have seen, but we need them in borderline cases. And that's important. So borderline situations with unfavorable different morphology, there we see the potential of BCM or PRF, PRGF technique. So I would like to give all the acknowledgements to the people who helped in the last 20 years. This is our grandfather here. You see Bob Schenk and all the other. You see lots of very bright young people. And this is Jordi from Spain, and this is Rick Myron, a Canadian who will come back to the States now. And this is really amazing to work with these bright young people, because they understand this cell biology business. and they really helped us to get a better understanding. If you should have ever an idea to come to Europe to a course, then come to Bern. We have 3 excellent master courses with this video technology handout I mentioned already. And with that, on time, we have 10 seconds left. Thank you very much for your very kind attention. Thank you.